Good morning, everybody, and thank you for the opportunity to share highlights of a collaboration between the Phoenix VA and the I-ELCAP for the past 12 years. Really exciting for the past 5 years. Everybody understands the concept that lung cancer screening is today the cure for lung cancer. The question is, how do we make screening more efficient, equitable, and offer a greater value? At the Phoenix VA, we try what everybody else tried first, which is a push system where we want to rely on primary care providers to do the bulk of the work and then refer the patients to radiology for screening. That doesn't work, hasn't worked for us. We have looked periodically, and about 1 of every 4 people that are sent to radiology for screening from primary care are an inappropriate referral, wrong patient, wrong test at the wrong time. The patients don't even know why they're there. And everybody's very upset with the process. So at the Phoenix VA, we changed about 5 years ago, almost 6 years ago, to a process we call precision outreach. It's a centralized team. We told the primary care providers we will take care of lung cancer screening and keep them in the loop. And precision outreach is all about using existing actionable data from the medical record to produce the list of patients in our hospital from 120,000 patients who are the most likely to be eligible for and benefit from lung cancer screening. By doing that, we pool the patients. We don't wait. If there are no consults, we call patients from that list. We talk to the patients on the phone, verify the data in the medical record for eligibility, explain lung cancer screening benefits and risks, and if the patients agree up to participate, and 90% of them are agreeing to participate, then and only then we order a CT at the convenience of their schedule, and that's the only time that they come to the hospital or to the mobile unit or wherever they're going to get their imaging. All the data from our patients is captured in a VA I-ELCAP system. Used to be called the VA Pulse I-ELCAP because of a source of funding. It's the VA I-ELCAP system. And in that system, we capture medical information in a structured format and also the radiology report in a structured format. That obtaining of information is a working tool, is part of the workflow. There is no double entering of data in any other database. The data goes straight to the medical record, so it's fully integrated with the electronic medical record. The dashboard is what gives us the flexibility to make the program more efficient and equitable. When we start noticing, because this is a real-time process, that we are lagging on representation from rural areas, we dial the dashboard by zip code, by clinician, by areas in the state, and we start calling patients from those facilities. So in Phoenix, 15% of our patients are from rural areas, but right now, 30% of the people that we are screening are from rural areas because of the dynamic dashboard that we use. Similarly, when we start seeing lagging of females representation in the lung cancer screening program, we kind of do a stand down, and for a couple of months, we emphasize calling eligible female veterans for screening. In addition to that, we take care of passive clinics where people are not being very active and helpful. And there are many other features of the dashboard. I can answer questions about that later. This is our workload for the past 5 years with 1 lung cancer screening coordinator that we could manage about 3,000 patients in the workflow. And when we were hitting about 4, we got permission to add another lung cancer screening navigator. And now we are adding 2 more this year. So we have already enrolled what we anticipate is about 28% of the cohort we will have. And we anticipate we're going to be able to, by the next 2.5, 3 years, have 100% of our predicted cohort enrolled for screening at the Phoenix VA. These are the results of our nodules management program. We're sending overall from baseline and annual CTs, about 1% of our patients are going to biopsies. We have performed 52 so far, only one serious complication, diagnosed 46 lung cancer, and 25 of those are early stage. So we're already staging better than the incidental lung nodules program. In addition to that, of course, we have coronary artery calcification scores, and this is the tabulation of those results from 0, mild, moderate, or severe calcification. And what we are struggling is what we were discussing this morning, how to better use that CAC scores information. Is the information the same for men versus women? And also, we're struggling with this concept of the power of zero. Is it really zero? Because when we look at the screenshot, and we look at this every day, this is a dynamic dashboard. This is the cohort of patients we have enrolled in our lung cancer screening program. And as you can see on the lower left, the pie chart, 80% of our patients for the past 6 years that have enrolled are still participating in the program. It's very efficient and the retention is very good. But the next pie chart that you see there, the dark blue and the orange, are the people who have a risk for atherosclerotic events greater than 7.5, intermediate or very severe. And we do that, as you can see at the top of the columns, by using the variables for calculating the risk of atherosclerotic events, the pooled cohort equation. We calculate this. This is using an AI tool directly in the medical record. When we give feedback now to the primary care providers, we talk about nodules, we talk about coronary artery calcium score, and we talk about multiomics atherosclerotic risk that combines medical, laboratory, and imaging information. But there are questions. 10% of our patients enrolled in the study are dying, and obviously they are not dying from lung cancer. They're dying mostly from atherosclerosis. And there are opportunities. I highlighted here one person, 51-year-old African-American person, who by the time we enroll had already atherosclerosis. During the period that we're screening this person, is having more atherosclerosis events, and yet this person was never in statin before. The other problem that we have found is that the medical record is scarce on smoking history documentation, and the PCE equation for atherosclerosis relies on smoking status, yes or no, to calculate the risk. So if anything, the PCE calculation of risk is underestimating the risk in the people we are screening for lung cancer. That was my question to the cardiologist. Have we looked at this cohort specifically? So now, as I was discussing with Claudia, we're collaborating with MD Clone that allows to now dial back and find out what happened with these patients before we enroll them in screening. And here is a snapshot of what the data looks like. This is the first 2,000 patients that we enroll in the program. So in the middle is the screening note, the intake note, and the baseline CT execution. By the time we enroll these veterans in lung cancer screening, 46% of them already had an atherosclerotic event, heart attack or stroke. And we enrolled them in screening. 54% did not have atherosclerotic events by the time we enrolled them, but in the next 4 years, 11% of those have had at least one, if not more, atherosclerotic events. And of the total group, 10% of these veterans have died while participating in our lung cancer screening program. We have also found, sadly, that about 40% of veterans that we're screening for lung cancer are technically eligible for treatment with statins, and they are not being treated with statins. So there are several opportunities for intervention for both primary and secondary prevention of atherosclerotic events in our lung cancer screening program, and we plan to optimize that at the Phoenix VA and hopefully throughout the whole VA system in the nation. We're gonna run these queries that you're seeing here in about 1.7 million records that are available to us through the VA database to see the extent of this burden and the opportunities to improve clinical outcomes. The other thing is, this is the Sankey plot showing how you manage risk for atherosclerotic events if you rely only on coronary calcium scores versus using the pooled cohorts equation, the medical and laboratory information. And the notion is that if you only rely on coronary artery calcification scores, you may be giving the patients false sense of safety, that because they have no or zero or very low calcium, they are okay. That may not be the case. I heard the answer to my questions this morning, but I'm not totally convinced yet that that's the case. So we'll keep learning about that. Our dashboard in the VA is being funded by the Million Veterans Program and the Department of Energy at the Oak Ridge National Laboratory. And we are now going to be adding to that clinical dashboard information of previously unknown risk factors that are already in the medical record, information from the genetics findings in the Million Veterans Program. And hopefully, before the end of this year, we're going to start testing computer-assisted AI radiology software to see if we can also not only add efficiencies to the program, more efficiencies, but also learn about other imaging features that can help us predict risk for lung cancer and atherosclerotic events. Thank you for the attention.